Hello, and welcome to your first mini lecture of the semester. I am Professor Zeller, and we are going to talk a little bit about postpartum. Postpartum means after the baby has been born. So we are talking about the postpartum mother, whether she delivered vaginally or by C-section, and some of the important pieces of assessment, history, different risk factors that pertain specifically to the postpartum period. So when we start to think about the postpartum mother, some history and delivery information that we focus on if you're getting report on the patient or if you're giving report to a nurse taking over for a postpartum mom who you helped deliver. Important information would include medical, surgical history, some lab status values, and then the delivery summary information. So when we look at mom's history, we pay attention to her gravidas and paras. Gravidas refers to the total number of pregnancies a woman has experienced, regardless of the outcome of pregnancy. Para indicates how many of those pregnancies have lasted past 20 weeks and what the outcome of that delivery was. And we'll get a little bit more into detail to that in class. Different comorbidities the mom might have. We would all like to believe that moms who are having babies are rather healthy, active individuals, but that's really just not the case. Moms' comorbidities have increased over the last 10 to 20 years. We have a lot more percentage of the adult population who have medical comorbidities, and we are really good at keeping them pregnant nowadays, much more so than we were 30, 40, 50 years ago. So comorbidities such as hypertension, diabetes, asthma, blood or clotting disorders, anxiety, depression, other mental health diagnoses, all of those things are very common during pregnancy and in the postpartum period. So we want to know which of those increase our risk factors for different problems and make sure we're integrating those into the plan of care for the mom. Allergies, of course, are important both to food and medications. Chosen method of feeding, whether mom has decided to breastfeed, bottle feed, or combination feed. We're going to want that information. We educate moms to choose that during the pregnancy so that we can provide education prior to delivery. And then after delivery, we want to support whatever mom's decision is in the best way possible. Lab values that are important to the pregnant and postpartum mom include her blood type, Rh status. This is the positive or negative connotation that you're used to seeing on a blood type. This is very important for the postpartum mom, especially if she is negative Rh status. And we're going to go in a little bit more detail into that in class of why that is so important and what we do about it. We would like to know mom's HIV status, her hepatitis B and C status, rubella status. RPR comes back as reactive or non-reactive. RPR refers to syphilis. So the test doesn't say syphilis. The RPR stands for reactive plasma region. But ideally, obviously, we would like that to be non-reactive. GBS is group beta strep, group beta streptococcus. This is a normal flora found in the vaginal and rectal tracts of upwards of about 40 to 50% of women. It doesn't actually cause any issues for the woman. It's only about sexually transmitted about 5 to 10% of the time, but it doesn't cause any issues for a sexual partner either. The only person that it causes issues for is an infant who is being delivered via the vaginal route. So we're going to talk about why that's important and what we do about it during delivery and how we would follow up upon that in the postpartum period. Some delivery summary information that we find very important would be the type of delivery, whether that be a vaginal delivery, an operative vaginal delivery, or a cesarean section. Any complications that associated with delivery, such as if there was an infection at the time of delivery, if there were delivery complications such as a shoulder dystocia, did mom experience increased bleeding after delivery? All of those things play into our plan of care in the postpartum period. So those are all very important. Presence and degree of lacerations or episiotomies. Lacerations are spontaneous tears to the perineal area, whether that be vaginal, cervical, perianal region. Episiotomy means the provider made a cut purposely. So we treat these things very similarly because essentially they are the same trauma to the tissues. However, lacerations occur spontaneously and episiotomies are done purposefully with surgical instruments. the time of labor and birth. So the total time mom was in labor as she labored, how long she pushed for, and then the time of delivery. That is important for both mom and for the care of baby. A lot of assessment pieces are directly related to the time of birth, so that is important. Rupture status. So when did mom's membranes or bag of waters rupture? And so not only what time did that happen, but what color the fluids were when they ruptured. And that kind of plays into some different risk factors we know she is at increased risk for, as well as increased risk factors for baby. And then, of course, the fundal firmness or presence or amount of bleeding. We are going to talk a little bit more about that when we talk about assessment. The fundus is the top cul-de-sac and portion of the uterus, and we pay very special and high priority attention to the fundus in the postpartum period, and we'll talk about why and how we do that as we move on. Vital signs for the postpartum woman, the normal expectations are very, very similar to the normal vital sign expectations for any other average adult. Okay, so our low threshold for blood pressure is about 90/50. Our high threshold is 140/90. So above 140/90, we get concerned, okay, or below that 90/50. Pulse, we expect to be about between 50 and 110. You'll notice that that top threshold is a little bit higher. A lot of times, especially immediately after delivery, moms do have an increase in pulse. This is compensatory to the decrease in blood pressure they have right after delivery because of expected blood loss. There's also pain associated with increasing pulse and a little bit of anxiety and stress with the birthing process as well. So we give them a little bit of a buffer range up to that 110. Anything above 110, we would definitely consider tachycardic. Respirations are the normal range you would expect for any other adult, 12 to 20. Temperature up to 100.4 is normal. Okay, anything above 100.4, we would absolutely classify as a fever. However, we know that postpartum moms, especially in the first 24 hours, run just a little bit of a low grade temp. So, a little higher than that 98.6 range where we're really comfortable with, but it's not a fever, and usually it's due to dehydration more than anything else in the first 24 hours. Pulse ox, we expect to stay steadily above 95%. I know in general med surge patients, 92 or 93 is our cutoff, and it makes us really happy. We are a little bit more stickler for oxygen saturations in our pregnant and postpartum patients, so we like to see those above 95%. Pain is very patient dependent, and it's influenced by a lot of different factors in the postpartum period, i.e. the type of delivery. We usually have moms have more pain with a cesarean delivery than a vaginal delivery because they have a very large incision. They underwent major surgery. Infections, if we have an infection of a wound or the uterus, that also increases pain, tenderness, and the subjective feeling of pain for moms. And then any trauma. We talked a little bit about those lacerations and episiotomies. There are some complications with delivery that increases pressure and trauma to not only the perineal tissues, but the uterus and the abdomen itself. So if we know that those have happened, we expect mom to have more pain. So we deal with that very subjectively and patient independently, and we'll talk a little bit more in depth about that in class. So a focused assessment for a postpartum mother. Of course, we are still doing our general head to toe. So we're still listening to the heart sounds, still listening to the lung sounds, still asking about pain. We don't focus as much on things that we don't expect mom to have problems on. Meaning, a typically healthy postpartum mom who doesn't have any neurological deficits or disorders, I'm probably not going to check all of her cranial nerves, right? I don't anticipate problems with that. If something in her assessment changed, then we could always add that assessment in. So thinking about what applies to your patient and why is very important. The mnemonic bubble heat, and I promise I didn't make that up. That's been used for years to kind of help people remember their focused postpartum assessment. Bubble heat. So breasts, uterus, bowel, bladder, lochia, which is the vaginal drainage, discharge, bleeding that we have in the postpartum period. Episiotomy or lacerations, which we've already touched on. H, hematologic status, and Homan sign. Homan sign is not evidence-based, but some providers will still ask that you do it. Homan sign is checking for deep vein thrombosis. And pregnant and postpartum women are at an increased risk for blood clots, especially in the lower extremities, and we'll talk why that is later. But Homan sign is there to remind you to assess for blood clots, especially in the lower extremities. Hematologic status referring mostly to the hemoglobin and hematocrit changes that happen between a pregnant woman and a postpartum woman. Some of those changes we expect, some of them are normal and some are not normal. We also pay close attention to the white blood cell count, and we'll talk about what differences we see in those. And then E for emotions, because pregnancy, delivery, and postpartum wreaks havoc on hormones within the body. Pregnancy changes hormone levels and regulation drastically, as does the postpartum period. So we pay very close attention to those expected normal changes and then abnormal concerning changes in a woman's emotions and emotional regulation. Extra assessment pieces and focus in addition to our focused postpartum assessment for a mom who is delivered by cesarean, meaning that surgical removal of baby through the abdomen. We have increased levels of pain and different methods of controlling pain for C-section moms, different medications, sedation, and side effects given what methods of anesthesia they were given to deliver via C-section. Bowel sounds and peristalsis. Major surgery on the abdomen has a direct effect on peristalsis and the movement of the large and small intestines. So we have special assessments and kind of implications for those. Urination and catheterization. Moms who undergo cesarean deliveries have a Foley catheter for a most of the time short amount of time. It usually goes in right before surgery. We leave it in about 8 hours after surgery. But we want to make sure that after that catheter removal, mom is able to void on her own, empty her bladder completely. We don't have any signs of infection from that catheter being used, and those other assessment pieces. Obviously, with a C-section delivery, we have an incision that we now have to assess and pay attention to. So assessment of that incision, normal expectations for that incision, cleansing and care, hygiene practices of the incision, and what to educate mom about for incision care. And then ambulation and activity. There are different restrictions for moms who have C-sections than there are for moms who have vaginal deliveries. So we pay a little bit extra attention to how we are counseling her to get up and move, what her limitations are, when those limitations go away, and special instructions of what to report to their provider as to what is normal and what is not normal. And then planning ahead. So different history, whether medical or surgical, that it pertains to mom, different findings in her delivery summary, findings on our assessment, all play into our expected plan of care for mom. We pay special attention to risk factors in the postpartum period. We know that certain interventions and findings increase mom's risk for postpartum infections. We know that different procedures and delivery methods increase mom's pain in the postpartum period. Different medications that we use to not only intervene on different problems or manage different issues for mom, also medications that we use for comfort care, pain control, any medications we are using for comorbidities management, all of those different pieces. Risk factors for a postpartum hemorrhage, which is the number one complication in the postpartum period. Not only is it the most prevalent complication, it is also the most deadly complication for moms in the postpartum period. Maternal infant bonding and feeding, and what stressors are placed on that bonding dependent on mom's assessment, mom's alterations to normal, if baby is separated from mom for special care needs, and then stressors and successes with feeding between mom and baby, especially a lot of attention to breastfeeding because that is typically more challenging than bottle feeding. What support mom has at the bedside? Does she have a support person present? Does she have a lot of family support? Will she have support when she goes home? Social stressors, needs, and resources. In a perfect world, all moms would go home with a great support system, all the resources they need to care for themselves and baby, plenty of time off work and other adult duties to rest, recuperate, heal. But we know that's really just not the norm for a lot of moms who are taking babies home. So anything we can do to identify potential risks and problems early, and then use whatever resources we can give that are at our disposal to best set that mom and baby up for success, especially once they leave our care. And then managing any comorbidities in the postpartum setting, what that looks like, dependent on what the problem is and how that changes as mom's needs change in the postpartum period for healing and promotion of health. That is the conclusion of our mini lecture. I try to keep these short so that you have just some information to think about prior to coming to class. We will delve deeper into the postpartum assessment and complications when we meet on day 1. I can't wait to see you guys. Have a great next week.